Hello, everyone, and welcome to the New York Hypermobility Collective. My name is Dr. Melanie Carminati. I'm a physical therapist. We're joined this evening with Dr. Jason Sieferman and Dr. Rachel Friedman. Our topic for this evening is gynecological and pelvic health considerations. This is a third webinar of our series of webinars. We've covered introductory topics regarding EDS and HSD, as well as orthopedic considerations. And so this evening, we're focusing on this topic. At the end of the presentations, we will have time for question and answers, so stay around for that. Again, this will be recorded, so we will send out the recording afterwards. We'll be starting with Dr. Sieferman.
Hello, everybody. So I'm going to give a brief overview of pelvic pain as it's associated with hypermobility. And of course, this is a massive topic, and I am not going to do a textbook's worth of information in 20 minutes. So as we dig into this, what is the pelvis? So we draw our boundaries here. So with the ring of the pelvis, there's the bony ring, there's the spine, the base of the spine, there's all the internal organs, there are the hips, all the muscles, tendon, ligaments, and joints that surround it, the nerves that go through this area. We think about the bowel, bladder, reproductive organs, and blood vessels. Often we forget to think about the blood vessels, but they play a role with hypermobility and pelvic pain. So all of these parts are considered. When we think about the pains that can be caused by hypermobility, generally, these are the structures we're thinking about. So the spine, of course, hypermobility in the spine can wear and tear the disc, the joints, the surrounding structures. Things like transitional vertebra are more frequently found in those with hypermobility, which can also be pain generators. The pelvic ring, which includes the two ilia and the sacrum. So we have the sacroiliac joint and the pubic symphysis as the points of contact. Instability of this ring doesn't just cause pain in those joints, but it allows jostling, tension, movement of anything inside the pelvis, because that pelvic ring is really responsible for much of the stability of that pelvic structure. The hips, which although they're outside the bony ring of the pelvis, they do play into the pelvis, and the hip muscles go inside the pelvis, and the nerves pass along through these areas, so they can all be involved. Hernias. And hernias can involve a few different areas, just above the pelvis where the inguinal hernias are, or femoral hernias, and then obturator hernias. Lots of opportunity for hernias to cause pain. Vascular, like pelvic congestion or May-Thurner, Nutcracker syndrome, things like that, occur more frequently with hypermobility. And of course, issues with the internal organs. So rectocele, prolapse, things like that, chronic constipation. Generally, any of these structures can cause pain, primarily due to hypermobility. Then once we identify primary pain, we want to think about secondary pain. And secondary pain arising from the instability can come about ultimately from impaired mechanics. Obviously, if something is not moving properly, you're not able to use it the way it's ideally, designed or evolved to be used. And as a result, you'll misuse it. And then there's often compensatory balances that occur in other areas. So whether the structure that's being misused becomes a source of pain, or a structure that ends up compensating and taking stress because the structure that's not moving properly is not taking the stress that it's meant to take, impaired mechanics lead to pain. Labral tears on the hips. So the hip, if it's hypermobile, if the ball is not stable in the socket, it will tug and tear and pull at the labrum, or it'll pinch the labrum, and those will tear and degenerate. Disc herniations in the low back, joint overuse, which I kind of mentioned in impaired mechanics. But when we think of joint overuse and hypermobility, it's not like the entire joint is equally overused. It's more that a portion of the joint that gravity pulls the joint into, or the mechanics of use pull the joint into, it tends to be one part of the end range of the joint that gets repetitively overused. And so it degenerates more quickly because the forces are not spread across the joint so evenly. It's easier to think about this in the knee, because the knee, if there's misalignment between the upper leg and the lower leg, you see the leg's not straight, it's bent at the knee to the side, like varus or valgus deformity, you'll asymmetrically wear the medial or the lateral aspect of the joint. Muscle guarding, of course, this results from any pain, any instability, any potential pain, any impaired mechanics causing compensatory motion will lead to muscle guarding. And of course, with chronic muscle guarding, you're overusing those muscles. Where those muscles attached to the bone, called the inthysis, can become overused. The bone can react to that. And the tendon in between can be strained and torn and overused as well. And then, of course, neural tension. So if something is stretching, if something is moving, if it pulls on a nerve, if there's a nerve that goes through that structure, whether it's a hernia or the sacrospinous ligament or the obturator foramen where there's a hernia, like you can have tension on nerves. And then, of course, nerve entrapment, just associated with the hypermobility as well. And aside from primary and secondary pains, we also have to think about sensitization. And when we say sensitization, we really mean the nervous system has learned to be hyperreactive. I say like the nervous system holds a grudge. So this can happen if there's severe chronic nerve pain or visceral pain from one cause, or it can happen if there are multiple simultaneous sites of pain in the same region. And generally, that's more common. So you may have a little bit of hip impingement, you may have an inguinal hernia, and you may be okay with both of these things, but then suddenly you have endometriosis, or you have chronic constipation, or you have a UTI, and then the summation of pain from these three things going to the same area of the spinal cord triggers the nervous system to become sensitized. And what that means is the nervous system just pays more attention to that area. And normal sensations start to become interpreted as painful, like light touch, pressure, things like that. So when we're assessing and thinking about pain related to hypermobility, we're thinking about the primary pain sites, we're thinking about secondary pains, and then we're thinking about sensitization in the nervous system. So we're going to dig into each one of these in a bit more depth. And I apologize, I'm going to rush through these pretty quickly because otherwise we will be here all night. So if you want to talk about anything later, I'm happy to chat later. We can talk in the question and answer session. Let me know. I'm happy to be of service. So when we think of hypermobility and the spine, we think first of instability. So is there spondylolisthesis? And this is where one bone slides relative to the other. It can slide to the front, it can slide to the back, or it can even slide side to side. There is the primary instability itself, and then there is the guarding response to the instability. And both of these things can be problematic. When the tissues are hypermobile, the discs are also hypermobile. The ligament that holds the disc in place is easily stretched as well, and more easily stretched. And especially if there's instability of the spinal segments above or below, then that can lead to wear and tear on the disc, herniation of the disc, and any issues with the disc. It's just more common to happen in those settings. Spinal nerve irritation also comes from disc herniation, comes from tension. When a disc herniates and then it heals, the nerve next to it will often get stuck to that disc. So there's a point of adhesion of that nerve. And then if there's any other stretch that occurs, it pulls on that adhesion point. That can be a source of pain. 1, 2, and 3 happen in non-EDS people as well. It just happens more commonly with EDS because the ligaments are responsible for holding all of these things together. Now, other things that do happen more commonly with hypermobility, transitional vertebra, that's what this picture is over on the right, where there's a Bertolotti. You can see the arrow pointing to this area of pseudo-articulation, where the lowest lumbar vertebra should be fused with the sacrum, or it should be separate. They shouldn't be rubbing, but that can definitely be a source of pain. So spinal instability, disc herniation, spinal nerve irritations, adhesions from those nerves, that happens in the normal population, even without EDS. It's more common with EDS, just because the ligaments that hold everything together are stretchy and they're easier to be injured. Transitional vertebra, such as the Bertolotti syndrome, which you see over here with the arrow, shows this area of pseudo-articulation. This happens in 36% of the population, doesn't always cause pain. It causes pain from rubbing. And of course, if there's more mobility in the area, there's more rubbing. If there's more rubbing, there's more pain. So we tend to see Bertollotti more often as a pain generator in people with underlying hypermobility. Spina bifida is what happens when the neural tube doesn't close perfectly when the fetus is being formed. The posterior elements at the base of the spine are not always fully intact. There can be neural related issues to this. Tethered cord happens often in association with Chiari, but basically the base of the spinal cord is tethered down and it doesn't allow it to move freely. So there can be a point of neural tension on the sacral roots, which can cause sacral pain, usually rectal pain, genital dysfunction. And then finally, Tarlov cysts, which is always a fun topic because they show up frequently on MRI, but they're so very rarely a source of pain. And there are surgeons who make it their livelihood of treating Tarlov cysts, but as I said, they're frequently present. They're rarely the actual source of pain, but it's easy enough to do diagnostic blocks and tease that out. Looking at the pelvic ring, starting at this image at the top, I sort of went through this ilium, sacrum, sacroiliac joints, pubic symphysis in the middle. With the pelvic ring, there are also some stabilizing structures that can be involved with pain. So the sacrospinous ligament, along with the sacrotuberous ligament, provides stability to the sacroiliac joint. If the sacroiliac joint is hypermobile, there will be extra tension on the sacrospinous ligament and the sacrotuberous ligament, which themselves can be painful just from the extra motion occurring, the extra stress on those structures. But separately from the direct ligament pain itself, the pudendal nerve also crosses over the sacrospinous ligament. So if there's tension on the sacrospinous ligament, it can put tension on the pudendal nerve. Hernia sites. So the next picture down, that shows you all of the different potential hernia sites that can occur in the front of the pelvis. There's a few, right? So when the tissues are lax, when they're more easily stretched, the opportunity for hernia is improved. And the most common ones we see, inguinal, femoral, and obturator. And these each affect the nerves that are going through those sites. Hernias cause pain in 3 different ways. Number one, the nerve that goes through the site is often irritated by the herniated material, which is usually fat pushing through. So basically, each of these sites, it's a canal, it's a place, a tubing where the nerve goes through and some other structures go through. There's not meant to be anything else going through there, but fat from inside the abdomen can push into there and crowd out that space. And in crowding out that space, it can irritate that nerve, and that's probably the most common symptom. So inguinal canal will often cause pain down to the testicle in men, to labia in women. Femoral canal will go down the front of the thigh. Obturator foramen is inner thigh, and both the femoral and obturator, and even the inguinal a little bit, can mimic hip pain. So it can be a little bit confusing because those nerves are irritated, the area becomes sensitized. So irritating the nerve is one way that hernias cause pain. Second is the material inside the hernia can be squeezed because it's compressed into that site. And that visceral fat also has sensation, and that usually goes through the sympathetic nervous system. So it's not completely uncommon for inguinal hernias to cause bladder sensitivity or frequent urination or pain like that. And then the final thing is the abdominal wall sort of reacts to this extra pressure, that extra stress, and contracts to tighten to try and keep things from going through, but yet it cannot effectively do that. So you end up getting abdominal wall pain in response to a lot of these hernias as well. Pubalgia. Pubalgia by itself basically means pain at the pubis. We use this as shorthand for a sports hernia. And a sports hernia is also not the best name for it because athletic pubalgia sports hernia is not always driven by athleticism or by athletic activity, although, if you're a runner, soccer player, anything like that, it can happen frequently. But essentially, this bottom right image, you see there are vectors of forces pulling up on the rectus abdominis and down from the adductor longus, and they both attach right at the pubic symphysis, right at the same place that the inguinal ligament attaches. And so these structures come together, and it's a common point of strain, and you can develop a sports hernia at that point. And then osteitis pubis is at the pubic symphysis, this bottom image. If there's extra rubbing of the pelvic ring, then you can have irritation, wear and tear at that pubic symphysis. All right, hips. Labral tears can be from chronic instability or trauma or both. And of course, you can also have hip impingement on top of this. We're not speaking about hip impingement because that's not a very specific hypermobility issue, although it can also happen in those with hypermobility. So labral tears can be just from the chronic instability, just from the hip bobbing around in the socket, pulling on the labrum, bumping the labrum, irritating labrum, or it can be from trauma with dislocation. And of course, the trauma will worsen the hypermobility. When there is pain or instability of the hip joint, there will naturally be forward rotation of the ilium. So there's going to be rotation at the sacroiliac joint, just to put more stability on top of the hip, just to cover the hip better, because the hip is anteriorly unstable, more so than posteriorly. So the ilium will rotate forward. Often there's a bit of hip flexor activation to keep the hip a little bit flexed because that pushes the hip back in the socket. So a lot of people will complain about iliopsoas pain or iliopsoas bursitis, but it's not really that. It's really the hip. They're just feeling that muscle because it's being overused. On the posterior aspect is ischiofemoral impingement, and this can affect the sciatic and posterior femoral cutaneous nerve. And then also the athletic pubalgia, because the adductor longus is another stabilizing muscle of the hip. And if it's pulling at the pubis, that can trigger it as well. Guarding of the hip, I mentioned the iliopsoas in the front, the adductors in the front, the tensor fasciolata, which will make the IT band tight. Not uncommon for hip hypermobility to cause knee pain radiating down. Piriformis in the back, which can put tension on the sciatic nerve and cause sciatica. Obturator internus can cause pudendal neuralgia by pulling on the pudendal nerve, or if it's enlarged, because that muscle is just chronically being overused, then it will actually occupy space. And this is where Botox can be helpful because it'll shrink that muscle so it doesn't take up as much space and push up against the pudendal nerve. And then, of course, bursitis, and lots of kinds of bursitis, lots of locations for bursitis, the iliopsoas, greater trochanter, ischium, which is really just from the muscles micromanaging the motion of the joint, right? So the core issue with hypermobility is that the ligaments in the joint capsule are loose. They do not do the job of holding the joint together, so the joint is loose. And the muscles then kick in to try to hold the joint together, but that's really not the primary job of these muscles. These muscles are really intended to control the motion of the joint, not stabilize the joint at this level. So when these muscles are constantly being used to stabilize the joint and micromanage the motion at every instant, you end up getting a bursitis. You get a tendinopathy. And if you see an MRI and there's like small tears of glute medius, glute minimus, tendinopathy, blah, 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 it's all from chronic guarding. And the hip is the primary source for that guarding, not those tendons, not the bursa. All right, hernias, I kind of went through a lot of this already, so I'll breeze through this. But when we think of hernias, generally pain with sitting, Valsalva, constipation, as I said before, it can mimic the hip, and it will frequently sensitize the nervous system. All right, vascular issues, pelvic congestion syndrome. If you haven't read about this, this is one here. It involves the ovarian veins. You get dilation there, you get backflow. Can be a significant source of pain that's difficult to pinpoint because each of these vascular issues, it's not like a hip or a hernia where people will come in and say, oh, it hurts here, or it hurts when I do this. It's really often a hurt all the time, and I can't really describe it, and I don't really know where it's coming from, but everything's just so sensitive. And sometimes patients don't even complain of it. They don't even recognize that they're sensitized, but they are. And then this is something I pick up on exam, or if we do some procedure and it's tremendously uncomfortable, sometimes we'll recognize that. And then that's when we start to look for these deeper things. Anytime we recognize sensitization as a process, we want to understand why it's happening, what's driving it. And so these are on the list of things we consider. And then, of course, internal organs, the bowel, constipation, prolapse. And then I'm going to let Dr. Friedman talk about the reproductive organs. What is our approach to this? As a pain doctor, I'm looking to identify the primary source of pain. What is the actual structure at the core that's causing all these trickle-down effects? And of course, it's usually the trickle-down effects that bring people in. It's the bursitis or the pudendal neuralgia or the pelvic floor. It's something downstream that's bringing people in, and I have to do the work of figuring out what the primary issues are. And as I said earlier, with the pelvis, by the time I'm seeing people, it's not usually just a singular issue. It's usually multiple issues, because usually single issues will get better and people will be fine. It's when things start to summate and they aren't addressed and they aren't treated, that's when they really start to become serious pain issues. And that's when the sensitization happens, and we really just have to reverse engineer that entire situation. So the goals: identify the reason for the pain. And when we're doing this, we're considering all of these things. So Is it just hypermobility? Was there some specific injury? Is there degeneration because of the instability or from a trauma? Is there also some hormone imbalance or deficiency in play? Because, of course, people with hypermobility, it's not like hypermobility is the only problem on the list. They have every other problem that any other human can have, too. So we have to consider everything that's involved. Could there be some autoimmune condition, which we know is more frequent, or mast cell, which we know is more frequent in those with hypermobility, or endometriosis, adenomyosis, which, again, also more common, we think, in those with hypermobility. Hernia, interstitial cystitis, things like that. Is there any primary neurologic issue like small fiber neuropathy, neuroproliferative stabilidynia, and then, of course, the vascular stuff that I mentioned before. So like when I'm seeing a patient, I'm not just thinking about the hypermobility and like everything on this prior screen that we went through before related to the hypermobility pain, but we're also thinking about how that plays into the bigger picture of anything and everything else that may also be going on with this same patient. And then, of course, we have to identify how all of these things interrelate, because usually there's a trickle-down effect, and usually it's at least 3 layers deep. And so we start to look for patterns. We look for constellations, and we want to make sense of these things because that's going to lead us to the core issue. And ultimately, we have to treat the core issue, even if the trickle-down effects have become their own independent issues. We still have to find the primary. So I'll just give you a few examples here. So if the hip is a primary issue, there's often tension on the psoas. Tension on the psoas can put tension on the lumbar plexus or the genitofemoral nerve, which can then cause leg pain or mimic a hernia. I just had a patient today who has hip impingement, who has testicular pain, had hernias repaired, didn't fix the testicular pain. We do an inguinal canal block, numbs the testicle, but doesn't take away the testicular pain. How does this happen? Presumably the psoas, because the psoas is guarding the hip. The psoas puts tension on the genitofemoral nerve, which goes to the testicle. When we do the hernia block, it's downstream from this entrapment. So it will numb the structure, but not stop the pain, if that makes sense. So we have to try and make sense of all these. Obturator internus guarding, pudendal neuralgia, piriformis guarding, sciatica, ilium rotation, sacrospinous ligament tightening, pudendal neuralgia, adductor longus insertion strain at the pubic symphysis, genital pain. That's all just from the hip. And there's more. This is not exhaustive. With hernias, it will cause hip pain. Just had a patient yesterday who was convinced that his hip was acting up. I examined him. It's hernia. He had a hernia surgery. He thought that was done. I'm like, nope, this is your hernia. We block the hernia. It takes it away. He's like, well, I thought that was my hip. I'm like, no, that's not your hip. Now you can feel what's left because your hip is not numb. So any pain that you're having in the hip, we can feel that now, and you can help distinguish that. Visceral pain with sensitization, interstitial cystitis type symptoms can happen with hernias. And then, of course, you can get acnes, abdominal cutaneous nerve entrapment syndrome. A lot of these things will cause abdominal wall muscle guarding reactions, which will cause acnes. Same thing kind of happens in the pelvic floor. We just don't have a nice acronym for it. Sacroiliac joint, tension at the sacrospinous, sacrotuberous ligaments, pudendal neuralgia, pelvic floor guarding, pubic symphysis pain, sitting intolerance, lumbar disc herniations. Anytime there's a lumbar disc, 2 things. One, it's innervated by the sympathetic nervous system, so it just feeds into the sensitization of the whole pelvic region. So lumbar disc pain can, reignite endo-type pain. So someone who had endometriosis, had it treated, it's all better, pelvic is calm, now herniates a lumbar disc. It's going to reignite that same sensitization pathway. So it may even present feeling like endo pain again, just because the nervous system's holding a grudge. So the lumbar disc itself can hurt, but then, of course, it can also irritate a nerve. Those nerves may go to the hip. They may go to the SI joint. It may amplify other pain because those nerves are irritated. And then finally, if there's neural tension from a lumbar disc, even if there's not an active disc pain or active radiculopathy, you can have leftover adhesions from a prior radiculopathy that allows there to be a point of tension on a nerve root that will need to be addressed in order for downstream pain to get better. So physical exam, how do we figure all of this out? We're really doing a very thorough physical exam to try and see what's going on. This is where I'm looking for those constellations of symptoms to try and understand what the primary issues are. We use imaging to the degree that it's helpful. Imaging really just gives us clues about your anatomy, and once we kind of see your anatomy and we know what's going on, we know what can happen. Even if it's not actively happening, even if it's not captured on that specific image, there are certain things that will give me clues that it is happening or was happening, and that factors into our problem-solving process. And of course, lab workup, mostly for autoimmune, just being thorough. And our general approach, which is still part of the workup process, because everything we do in terms of trialing different treatments either confirms or helps us adjust our understanding of what's going on in the body. So if there's sensitization, there's really 3 categories of sensitization, and you can have any or all of these 3 categories. One is neurologic sensitization, one is inflammatory rheumatologic sensitization, and then the other is psychological sensitization, like PTSD. And we want to sort of suss out which of those are in play, because anytime there's sensitization, we want to treat that first. The analogy here is if there's something on fire and the flames are so big that you can't actually see what's burning, we have to knock down the flames first. The flames are that sensitization. We want to get that under control, and then we can see more clearly what was driving it, because that's ultimately what we have to treat. So get the sensitization under control, then it will be more obvious. Is it a hernia? Is it a disc herniation? Is it the hip? What is it? So there's a few different ways: oral medications, IV infusions, sympathetic blocks. These are the ways we deal with neurologic sensitization. If it's autoimmune sensitization, we might do a course of steroid, we might do a course of an anti-inflammatory. And of course, if it's psychological sensitization, lots of biofeedback and ketamine therapy, talk therapy. There's a lot of pathways we have for this. And of course, pain psychology is essential. So get the sensitization under control, see if we can identify the primary structures driving the sensitization, and then we have to rule those in or out. So we will do diagnostic injections where the point of the injection is just to turn off pain from a structure, just to see if it's the source. And it's not meant to treat, but sometimes we'll often combine either steroid or regenerative medicine with that diagnostic block to see if we also get a secondary therapeutic effect. These are all things we talk through during the process, but just know we're looking to cover as many bases as possible with any intervention we do. And anything we do at this stage, again, it's iterative. We're trying to understand what's going on. We're trying to establish the flow, the cause and effect relationships, the cascade of symptoms. And the only way we can do that is by interrupting one of these structures by turning it off, or by treating something, just so we establish what role it has. And sometimes we do this and something will flare. And while we don't want to cause flares, it is a data point and it does give us more information. So it helps us know which direction to go. I'll give you a good example. With hypermobility, if we want to confirm that a joint being hypermobile is the source of pain, the sacroiliac joint is a great example. So SI joint pain with sitting puts tension on the sacrospinous ligament, tension on the pudendal nerve, pudendal neuralgia with sitting due to the sacroiliac joint. That's my hypothesis. If I want to test it, I have to stabilize the sacroiliac joint. So I could give the patient a sacroiliac belt, and if that's helpful, fantastic. But that's not a long-term treatment. That's just sort of proof of concept. Or I can inject the joint and fill it with fluid. If I fill the sacroiliac joint with fluid, then it becomes temporarily stabilized until the body absorbs that fluid. That will also give us proof of concept. At the same time, I might use prolotherapy with dextrose to try to tighten it and also get a therapeutic effect. If the patient responds well, fantastic. That's what we want. If they flare, there's a reason. And I have to figure out what that reason is. Might there be an underlying mast cell activation syndrome? Is there an autoimmune process? By stabilizing the SI joint, did we in turn irritate something else? Did we unmask the hip, for example? That will sometimes happen too. If the SI joint is being overused to stabilize the hip, and we take away the ability of the SI joint to be overused, then the hip will no longer be stabilized as much by the SI joint. We might unmask primary hip pain where there was actually no hip pain before, which is great, because then we know we actually need to stabilize the hip, and the hip is the reason the SI joint is hypermobile or being overused, which is the reason why there's tension on the sacrospinous ligament and the pudendal nerve is being aggravated. So there's 4 steps down that pathway, right? So that's the role of diagnostic procedures, and that's why it's a journey. And understanding the journey going into the journey is important, because it's rare that we understand everything fully the first time around. It's a little bit of a process. Sometimes we get lucky. Sometimes patients declare themselves with a very obvious and clear constellation that we've seen 100 times. And then we can say, great, this looks familiar. I'm pretty sure, I think I know what's going on. Let's try this and confirm it. But even then, you never know until you know. So once we've established that, we can move forward with treatment. The role of medications is really to keep you comfortable. And I explain to patients, there are two pathways we go down as we start working together. One is getting you comfortable so that you can enjoy your life. And that's why you're seeing me, right? I'm a pain doctor. It's my job to make you feel better. So I have to do that, at least in part, right? So we want to get you comfortable. But we also want to figure out what's going on. And that's the second path, is what's happening. Why is it happening? How did it come to happen? And how are we going to keep it from happening going into the future, right? Like, how are we going to reverse the course that this has gone down and redirect things so that you can enjoy the rest of your life? And through the process of us doing this, you will come to understand your body, what's going on, how that's happening, why those things happen, and what we can do about it. So each different treatment we try will either work or not work or have some reaction to. We feed that data point back into our bigger understanding of your body. And, all of this is education. So medications, we may use them to manage discomfort temporarily, stop an inflammatory process, reduce or reverse central sensitization. We may modulate the immune system, or we may use them for maintenance. It's not unreasonable to have some medications in play for a longer period of time just to keep things comfortable, or we may just revisit them for flares. Of course, physical modalities. So physical therapy is absolutely essential for hypermobility, and Pilates is basically my core religion for core religion. I didn't mean to make that pun, but there it is. It's my core religion. Pilates is my core religion. I'm going to put that on a t-shirt. So it's absolutely essential for not only building the core strength, but re-educating the muscles that have been being used to guard and compensate. We have to remind the body how it's supposed to be working, because at the point I'm seeing patients, there are all these compensatory behaviors using joints in ways they're not supposed to be used that we have to unlearn, stabilize the joint so you don't have to compensate, and then relearn how they're supposed to be used. And it's an educational process. It takes many months. And this is something Melanie's going to talk about a bit later because she specializes in this for EDS. So it's absolutely an essential role. Other things in physical modalities, sometimes we think about, and biofeedback is kind of like a cross between pain psychology and physical modalities, but biofeedback is basically where you can listen to the muscle activity in different muscles, and you can recognize and learn how to control tension in certain muscles. It's really a good self-awareness technique. We will work with chiropractors for hypermobility. We'll work with acupuncturists. All of these things have to be done, in my opinion, with a team-based approach, because there has to be a larger understanding of what's happening, why it's happening, how it came to happen, what are we treating, why are we treating it this way, what are our goals for that treatment, what is the expected outcome, and if something doesn't go as expected, what are we doing? And that's my job. That's why I'm here. All right, pain psychology. The important thing I want to say about pain psychology is it's not like normal talk therapy. Yes, these pain psychologists have a doctorate. They are psychologists. They can do normal talk therapy, but they also did an additional year fellowship in pain psychology. And their specialty is really knowing the nuances of pain, how it affects one's life, the feelings of guilt and resentment and anger that have to be processed, the anxiety that comes around getting better, and the fear that comes around getting better. There's a lot of very special niche issues with pain. There's PTSD and medical PTSD associated with pain, and they're very familiar and they know how to parse all of that. But separately, they are coaches. They know about the journey of diagnosis, treatment, and maintenance, the three phases of the pain journey. And they help coach patients who may have been going through this, but may not be optimally using the system, on how to best engage with their doctors, on how to best keep notes, how to keep a pain diary, how to really take ownership and control of the pain journey themselves, because that's the only way forward. And that's, again, why I'm an educator above all else. Each patient has to learn how their body works, why, how, what, all of that has to be understood as much as possible. And I'm here to help them figure that out. And then the pain psychologist helps them integrate that information and make choices about their body, choices about their life with that information in mind. All right. I'm going to gloss over this because you've probably heard enough from me at this point. We want to move on. Know that we have a ton of treatment options. The core treatment for hypermobility is regenerative medicine from my book, because the main issue with hypermobility is the ligaments, the connective tissue, are too stretchy, and we need them to be stronger and less stretchy. And we can do that using regenerative medicine techniques like prolotherapy, platelet-rich plasma, sometimes bone marrow. It really depends on the structure, what's injured, how it's injured, why it's injured, how we're going to keep it from getting re-injured. It's really looking at all of these things, putting it together, and choosing the correct treatment for the correct structure in the correct order. And that's what my job is, to help you figure that out and to educate you on the options so you can make the best choice for yourself. All right, that is me. Thank you very much.
I was like, will learn as much as I can about this so that I don't ever have to have somebody go through what I went through in terms of really trying to find somebody who knew what the heck I was talking about, because it's largely invisible. And we all know that, I only treat women, but we all know that being a woman and having an invisible illness is a winning combination. So it's really tough. So I structured the talk to talk first about the importance of hormones and the hormonal influence on the musculoskeletal system. I think it's a super important topic in hypermobility spectrum disorders. It doesn't affect everybody the same way, but for many, many patients, it's a huge issue, and certainly where I can come in and help. I'll talk briefly about pregnancy and hypermobility spectrum disorders, and then gynecologic manifestations and associations. So hormonal influences can affect people at any different stages, but the main ones are the big times of hormonal change and fluctuation. So puberty, pregnancy, and menopause. And I didn't find a lot of research in terms of, do people always or frequently find exacerbations at these times? But most of the reports are people note that their symptoms have onset at one of these big transitions, and they tend not to be times for people that are better for them. People who have been diagnosed with hypermobility spectrum in puberty, for example, sometimes pregnancy and or menopause can be challenging times for them, or at least it makes sense if you are sensitive to hormonal fluctuations to be prepared for that. We have precedents for this in other things. We know that injuries in female athletes can vary by cycle phase. There's a decent body of research about ACL injuries based on your menstrual cycle and the effect of hormonal contraceptives, whether or not that's potentially protective for ACL injuries. We know that frozen shoulder is much more common in postmenopausal women, and there's some newer research about frozen shoulder and estrogen receptors in the shoulder, and that's definitely an example of the interaction between joint, ligament, tendons, and our hormones. There's anecdotal improvement with testosterone in trans males. I could find absolutely no research on this, but of the trans males that I have seen, and again, just anecdotally, have done well with testosterone, which certainly makes sense in terms of building muscle mass, and speaking about the way that you treat hypermobile joints in terms of neuromuscular re-education and strengthening around the joints. I searched incessantly for, whether or not testosterone could be something useful generally for women in hypermobile spectrum disorders as an adjunct to treatment. I have not been able to find that, but something that I'm definitely keeping in the back of my mind. This complicated chart basically goes through what happens during the menstrual cycle. On the left is cycle day one, CD1, and then all the way to the right is the second half of the cycle. And you can see what happens with each hormone. You have an estrogen peak in the first half of your cycle, which is day 1 through 14 is the first half of your cycle, which is prior to ovulation. Excuse me, the follicular phase, and then the second half is the luteal phase, which is day 14 to day 28 in a typical 28-day cycle. The first half of your cycle, you make estrogen, and then once you ovulate, the ovulated egg makes progesterone. And estrogen tends to, as you can see, underneath the estrogen graph is relaxin. Relaxin tends to follow the estrogen peaks. So what tends to happen, and what a lot of people tend to report, is that during the second half of their cycle or around the fluctuations of their menstrual cycle, they have a worsening of symptoms. Relaxin is a hormone that does exactly what it says. It relaxes the ligaments and the joints. It can be a useful hormone, as all of these things can be useful until they're not. But, like in pregnancy, people have an increase in relaxin towards the end of the pregnancy to help relax the pelvis in order to facilitate delivery. But patients with hypermobile spectrum disorder or HSD, they don't need more relaxing. And so when there's more relaxin, their joints become looser and their muscles work harder, and that tends to lead to more pain and dysfunction. So you can see, looking at the graph of what happens during your cycle, I think there are a lot of patients who don't understand potentially that relationship, and every month is kind of like every week, what's going on, what's happening, what happened, why am I hurting now? And it can turn out to be a cycle where you have an exacerbation around right before ovulation, then you recover a little bit, then you exacerbate right before your period, and then you recover. So you don't get much time to move forward if you have short cycles and you're particularly sensitive to the hormonal fluctuations. So the question is, can we use hormones to our advantage? And I think so. I wish we could do more, like I said, with the potential for testosterone, but it's not that easy, obviously. So I always ask people to pay attention to their individual responses to the hormones. Like, I have them make those graphs and see, because HSD is such a multivariant, multifactorial disorder that, you got to look for patterns and to help you figure out what's going on. But if the same thing happens every month, even if you're not going to manipulate your hormones, but potentially just observe, like, I know that right before ovulation is a difficult time for me. Maybe that's not when you play flag football, Elevated estrogen and progesterone can increase laxity, like I said, and the luteal phase. And for a lot of my patients, we'll talk about continuous combination contraception, and that's it works by inhibiting ovulation. So those hormone levels are flat. And for some people, that's very helpful. At least, it gives you a certain percentage of relief from having that fluctuation and sort of rest recovery phase. For some people, hormones tend to worsen laxity. And again, that's super individual. Generally speaking, progesterone tends to worsen laxity in patients more. So I'll generally use a combination contraceptive with estrogen and progesterone if I can. Some people have a contraindication to using an estrogen contraception. So obviously I can't do that. People with migraines with aura or uncontrolled hypertension. But even in patients with mild contraindications, I tend to really try to work with their team to help them figure out how we can use their hormones to their advantage. There are some progesterone-only medications do inhibit ovulation. The Nexplanon implant, Depo-Provera, not all, but some. And so even like a Mirena IUD, it doesn't work by inhibiting ovulation all the time, but sometimes. So for some patients, they do get relief from that. And again, back to the testosterone, theoretically, it would make sense that it could increase muscle mass. There are significant side effects to using testosterone that a lot of patients don't want and could be potentially harm-inducing. So it's not something that I use regularly to treat hypermobility spectrum disorder, but I'm certainly very interested in. So just to generally talk about pregnancy, we'll talk about pre-pregnancy, during pregnancy, and postpartum. Pre-pregnancy for people with HSD, you might consider genetic counseling. As of now, I'm not aware of a known genetic defect that causes the hypermobile type of Ehlers-Danlos syndrome. That may change, hopefully. I certainly have seen research to that effect. But if you don't know what type you have, there are 14 now identified different types, and genetic counseling can give you that information. There may be testing that's available, like with IVF, if you had, for example, a classic type, that there is an identifiable gene that could be tested if it was of interest for you to know whether or not you had embryos that were affected. Certainly you would want to know if you had vascular EDS. That could cause potentially much more of a dangerous situation for you in most situations, certainly in pregnancy. Pre-pregnancy, you also want to address pain management. Pregnancy can be, because of the increase in the relaxin levels, amongst many other changes in pregnancy in the body that change, like you change your center of gravity, all that. Pain management is important to make sure that you're comfortable so that you can move, you can function. And there are certain medications that are safer in pregnancy. So going over that with someone pre-pregnancy is important. Obviously, for most people, getting pregnant involves intercourse, and that can be complicated in people with HSD. Certainly, there are safer positions and things that you can do if you have hip and pelvic instability. That's an important aspect to make sure that you can do safely. For some patients, I advise them to consider maternal fetal medicine or high-risk consultation pre-pregnancy because of some of the risks that we'll talk about during pregnancy coming up. So May 2024, a document came out that talks about the management of childbearing with hypermobile Ehlers-Danlos syndrome, and it's basically just a really, really large review of all the different data that's out there. And it basically, the take home of it is helpful because I think people didn't have much to go on before this. There is a slight increased risk of recurrent miscarriage. So not just one, not just two, recurrent is generally 3. There's an increased risk of bleeding complications. So as we know, people with HSD have or Ehlers-Danlos syndrome have more sensitive tissue, more fragile tissue. So you could imagine, you have a tear, it's going to bleed potentially more significantly, or you could potentially have a postpartum hemorrhage from various different sites that may be more challenging to address. There is an increased risk of fetal growth restriction, and I have some ideas about why that might be, but I'm not aware of exactly why. You think the fetus is free to grow, you are likely to have increased joint laxity and pelvic girdle pain. So, pre-pregnancy, if you know you have this, trying to get your team together and get people that can help you, get a physical therapist who can help you manage your discomfort, learn techniques to manage your discomfort, get a sacroiliac joint belt, things that you can do ahead of time to prepare yourself that these things may occur, might make your life a lot better. So I always refer people to people like Dr. Sieferman and Dr. Carminati, physical therapy. I have people learn about bracing, taping, support devices. There's tons. Having someone who can do manual therapy safely in pregnancy is completely fine. And learning how to continue to move your body safely. There are a lot of things that you can do to exercise safely in pregnancy. Basically, almost most things that are don't involve trauma to your body or your belly. But learning how to continue to be active and allow your joints to move is super important. This is a really sad diagram compared to Dr. Sieferman, so I think we can just move on from that one. Thank you. Delivery considerations. Again, anticipate increased risk of bleeding tissue or fragility. I usually suggest people meet with anesthesia regarding, any potential comorbid conditions and planning. Some people have reasons that they can't say you've had a spinal fusion. You want to make sure if you want an epidural or they need to be able to place an epidural, that they can place it based on what they know about your anatomy. Sometimes they want to see your x-rays. So trying to, not wait until you're in labor to determine these things is super helpful. Knowing, that you do have an increased risk of having a bleeding complication allows people to plan and take care of you safely. Patient positioning is, so can you just go back for 1 second? Patient positioning, in particular in labor, is super important. In particular, if you have an epidural, people sometimes, obviously in attempt to help patients, often will hyperextend hips to deliver. And if you can't feel what's going on, and again, I'm not saying you shouldn't have an epidural, you should have whatever you want, but you just want to be cautious of like what your normal range of motion is and make sure that your joints aren't being brought through ranges that could potentially cause harm to you for long periods of time and you're not aware. And cesarean delivery is really just for obstetric indications. I mean, each case is individual, but it's always people are always worried about pelvic instability, and vaginal delivery, which is a valid concern. But abdominal surgery is no joke for people who have pelvic instability either, and losing all of that abdominal muscular support. So I don't believe that it is generally recommended, and there's no data to support that. Postpartum is also really important. I feel like a lot of times people forget about this because, once the baby comes out, certainly, that is a large focus and it should be. But moms are really vulnerable at that time. The relaxin levels are dropping. And so people tend to their ligaments and joints start to tighten up. But if you're nursing, that sometimes can be delayed. In addition, it's super stressful if you've ever breastfed to know, like when your kid is freaking out, crying, and you're trying to feed them, a lot of times you're just, you're not cautious about your own ergonomics, making sure you're not doing weird stuff with your body, with your neck, with your back. Just thinking about those things to set yourself up for success. You can feed your child and not hurt yourself all at once. So making sure that you have a place that's set up where you can feed, or bring a pillow with you if you're going to feed while you're out, or use your backpack, or trying, or it's okay if you make choices that prioritize yourself. I would never tell anyone what to do about feeding, except to say that your pain and your health is important too. And there's always, can you go back for a second? Babies, there's always enough for babies to eat. Physical therapy, postpartum, super important, making sure you get back to, your strength and attention to your body and attention to ergonomics with infant care. Set yourself up to protect yourself, to protect your legs, your back, your hips. There's a lot of weird movements. I was just talking about this with someone today. You either picking up a car seat, putting a baby in a crib, they get bigger and bigger and bigger. And if you lift them wrong every single time, you could be lifting them incorrectly like 50 times a half day. You have to change their diaper every 2 hours. If you do that with strain on your back and your hips, you're just setting yourself up. So you can take care of your baby and take care of yourself. You may need to make the diaper table like at a height so that you don't bend. The cribs are ridiculous. There's not, I think, yeah, I'm sure it's for safety reasons, but those cribs that go up and down, they don't really make those anymore. So they're always just like a dead drop. So if you're going to be doing that, make sure that, you learn how to do that as carefully as you can. Tighten your abs, bend your legs, like get them in a bed when they can, just watch yourself so that you don't cause any unnecessary harm to yourself while you're taking care of your baby. So urogynecology is another whole area that people with hypermobile spectrum disorder struggle with. And that's basically sort of along the same lines as hernias. It's an area where if your connective tissue is looser and more lax, you're going to have areas that bulge into areas that you don't want them. So pelvic organ prolapse and bladder symptoms are very common in patients with HSD, and even in younger and patients who haven't had kids. A lot of people think, oh, well, you've got to either be older or have had like 5 kids. No, it's really always a function of, your constitution, what your tissue is like, and your environment, what you've done to that tissue. So for general pelvic organ prolapse, first line is dietary lifestyle interventions. So if you have things that are like pushing on your pelvis, things that make, if you're really constipated or you have a chronic cough, things that can modify the pressure on that area. If you're a smoker, you got to make sure you can modify those things best you can. Pelvic floor PT is crucial. I have some young patients who use a pessary. I have patients of all ages who use a pessary, which is like basically a little ring that you put in vaginally that can hold, well, there's a ring, there's all different shapes that you put in vaginally that can hold up different types of pelvic organ prolapse. Because as you guys know, most people with Ehlers-Danlos syndrome, for surgery is a last resort for all very similar reasons that, we talked about for pregnancy, like even just intubating somebody who has, potentially jaw instability or neck instability. It's a huge risk to take. So you want to try to maximize any conservative treatment that you can. And pessary is, it's not everybody's first choice, but it's definitely a great non-invasive option that can allow you to live your life. And surgery is definitely an option. And we talked about comorbid issues. And again, this is the different types of pelvic organ prolapse. Top left is a cystocele, which is the bladder extruding, and it can be to different degrees. Enterocele is the bowel extruding, or not the bowel itself, like it's through the fascia. But it kind of puts pressure on those tissues. Rectocele, the rectum, and then the uterus, you can see, can also prolapse. Symptoms of pelvic organ prolapse, they can be kind of tricky. Often people complain of a feeling of heaviness or fullness, or they feel like something's falling out. Sometimes they'll feel like there's a pulling or aching or a bulge in their pelvis. Like there's some people will say they feel like they're sitting on a ball. And some patients have difficulty urinating. Some patients will say they feel like they have to push something back up and it feels better. Chronic pelvic pain in general is again, as Dr. Seiferman said, it's super complicated, and there's many possible etiologies, often multifactorial, and takes a lot to go through it. The way I kind of think about it, I have a more narrow focus as a gynecologist, but I try to think about other things that it could be gynecologic, musculoskeletal, genitourinary, gastrointestinal. There's a lot in the pelvis. Gynecologic, people with HSD are more likely to have menorrhagia, which is heavy periods, painful periods, pain in their vulva or their labia, or dyspareunia, which is pain at sex. They can have musculoskeletal pain, vaginismus, which is a painful spasming with any type of insertion of the pelvic floor muscles, and broadly pelvic floor dysfunction, sacroiliac joint dysfunction, and various types of nerve entrapments. There can be genitourinary symptoms that cause chronic pelvic pain, interstitial cystitis, recurrent UTIs, prolapse, vulvodynia, and sexual dysfunction. Last, I just wanted to talk about gynecologic manifestations of mast cell activation, because this is something that I think a lot of people don't think about. Mast cell activation is a common comorbid condition with a lot of people with EDS. And the uterus and the vaginal mucosa are loaded with mast cells. So a lot of people, I think of it in other capacities, but it can lead to chronic irritation, itching, pain, bleeding. And there wasn't much data on it, but there are some case reports of people who manage it locally using topical Benadryl, cromolyn. I saw some case reports of people using like a douche. I mean, I don't generally advise anyone to use douching. In particular, the only time I've ever advised it is for people with, chronic irritation, itching, and pain that I thought was mast cell related. And for when you get it right, it works immediately. That's it. Thank you very much.
Okay, thank you so much, Dr. Friedman. I am just going to wrap up with a short presentation promise, and then we'll get into the question and answer. So again, my name is Dr. Melanie Carminati. I'm a physical therapist. I'll be speaking specifically today about pelvic floor physical therapy. I am also nationally certified as a Pilates teacher. I did cover Pilates integration in previous webinars, so I'm not going to go into too much detail with that today. Today, I'm going to focus on the pelvic floor. As a disclaimer, this is informational. This is not to give anyone a diagnosis or give anyone a specific treatment. If you are wanting medical care, seek out individualized medical advice from a provider like the providers presented today. Okay, so this is just some general information about hypermobility in terms of what we are going to be thinking of as a physical therapist, as a pelvic floor physical therapist. If anyone is coming in for pelvic floor dysfunction, for pelvic pain, prenatal, postnatal, we have to also consider all of the other comorbidities that go along with HSD and EDS. Pelvic floor physical therapy. What is our pelvic floor? So the pelvic floor is a multi-layered muscle group. I say it's a 3-layered muscle group. Commonly, I will describe it as 3 hammocks stacked one on top of the other with openings. If it's female pelvic anatomy, you would have the vaginal opening, the rectal opening, and the urethral opening. If it's male, you would have the urethral and the rectal opening. And then these muscles, these 3-layered hammock kind of muscles, they have 5 main functions: to support, acting and holding up the pelvic organs. There's sphincteric function, there's sexual function, stability, which is very important, as we all know, when we're working with people who have hypermobility and or HEDS, and also respiration and mobility. Whenever we're educating patients about the pelvic floor, we are also educating them about the deep core, which is the diaphragm, the transverse abdominis, and the lumbar multifidi. Those 4 muscle groups are all working together to maintain that intra-abdominal pressure and maintain the space. So if we are working on the pelvic floor, we're always working on those other muscles as well. So pelvic floor muscles, this is just a very simple image that shows you the variations or the differentiation, should I say, in the pelvic floor muscles from male pelvic anatomy and female pelvic anatomy. Here are the 3 layers. As a pelvic floor physical therapist, if someone is coming in with pelvic pain as their main complaint, and we suspect it is musculoskeletal, and we believe we want to be doing internal manual therapy, after a thorough assessment, we would be, with permission and with consent, doing internal assessment of the muscles and going muscle by muscle, kind of having this map in our mind to pinpoint specific muscles that are the source of the pain. When we are dealing with pelvic pain that is more musculoskeletal in nature, we're thinking of hypertonicity in the pelvic floor. That can commonly be a source of pain, especially for dyspareunia, which Dr. Friedman mentioned. And the pelvic floor muscles themselves, when there is hip instability, hip joint instability, they will many times be held in a state of spasm or just tightness or contraction to make up for that lack of stability in the hip joints. So when we're doing the manual therapy, you can really appreciate here in these images what the pelvic floor physical therapist will be thinking of when they're doing that internal pelvic floor treatment. This is just another image, pelvic anatomy, female pelvic anatomy. You can appreciate the pubic bone all the way back to the coccyx and just the orientation of those openings, as well as that hammock kind of effect that the pelvic floor muscles provides. There's also pelvic wall. So Dr. Sieferman talked about this pelvic wall when he was talking about the piriformis and the obturator internus. Right now, I'm only showing you the muscles, but as Dr. Sieferman mentioned, there are tons of nerves. We know the pudendal nerve is the main nerve that innervates the pelvic floor, but there are so many branches, and it does make it complex in diagnosing and treating pelvic pain, but understanding the anatomy is so important as a provider to be able to treat it efficiently. And so you can see in this image that pelvic wall that is connected to the rest of the pelvic floor musculature via that fascia. Pelvic floor considerations. So if someone's coming in with EDS and HSD for physical therapy specific for pelvic floor, I want to find out, is there an existing pelvic organ prolapse that they know of? Is there a history of pelvic pain? Is there a history of vulvar fissures? With EDS and HSD, there's skin sensitivity associated with EDS and HSD. Is there an overall orthopedic history of shoulder, knee, foot, ankle, hip dislocations? This all impacts the whole body and the whole stabilization in the body itself. But when we're thinking about birth as well, we want to keep this in mind because there are many different birthing positions, and depending on if someone is working with a midwife who's informed about EDS and HSD, they'll need to advocate for themselves and just inform that midwife or even doula about EDS and HSD and some of the modifications that they need for birth. Pelvic PT for pelvic pain. So we do the assessment. I mentioned some of the manual therapy already, but if this is chronic persistent pain, myself and my team at Inspira, we are always doing central nervous system and peripheral nervous system manual therapy first. So that would look like craniosacral therapy, visceral manipulation, vagus nerve work, and then we'll be doing the soft tissue manual therapy. So if those first layer pelvic floor muscles are hypertonic, we're going to work to release them. We do use radio frequency a lot in our office because it makes it more comfortable. As you can imagine, if the pelvic muscle is in a state of spasm and we're trying to do the soft tissue work to release it, it will be uncomfortable for many people. So the radio frequency is wonderful because it gives a warming sensation, and the effects of that are commonly longer lasting than just traditional internal pelvic floor manual therapy. And then for exercise, we're starting with diaphragm breathing. Please excuse my typo there. Lumbopelvic stability, of course, would be what we'd be working on. As mentioned, the hip and lumbar spine anatomy is so intimately related with the pelvic floor. If there is pelvic organ prolapse after the assessment, we would be focusing a lot on uptraining and Kegel strength, core strengthening, as well as pressure management, super important for people with prolapse, and then weight training. As Dr. Friedman mentioned, referral to a urogynecologist for pessary fitting as well. Some prenatal vaginal birth prep considerations for people with EDS and HSD. We do the overall assessment, and then we would just address what we find. I want to also say that in terms of what we would be reviewing proper breathing mechanics for vaginal birth prep, if that is that person's goal, proper strengthening to balance out that down training that we might be educating them in for that vaginal birth, as well as whatever postural reeducation and functional reeducation makes sense for that person. We all are squatting, whether we're aware of it or not. Every time you sit onto a chair, stand up from a chair, sit on the toilet, get up from the toilet, this is a squat. So that's one of the most functional movements that we all do on a daily basis, and making sure throughout the pregnancy that someone who has EDS and HSD is really recruiting from their muscular system during that time when, say, the relaxin hormone is kicking in more and their ligaments are even more lax than they were, and getting them to use the muscles is part of the physical therapy for prenatal, as well as recommending different external supports. As Dr. Friedman mentioned, SI belts is one thing, belly bands, We use a lot of kinesio tape in our office. So general recommendations for people who are pregnant and have EDS and HSD, I would say to be avoiding hanging positions with the upper extremities. There's some birth exercises or prenatal exercises that are given to some of my patients to help open up and create more space in the abdominal area. It makes sense, right? If you're pregnant and there's a little human growing in the abdominal cavity in the uterus, you want to try to give more space. But if you're someone who's hypermobile and or has HEDS, the hanging, especially if there's history of shoulder subluxation dislocation, we want to avoid. We encourage bracing on the wall, so transverse abdominis activation in standing, using the wall for feedback. We do avoid excessive bearing down reverse Kegel prep just to reduce any incidence of prolapse. We of course go over it, but we want to always balance that out with up training, breath, postural awareness, avoiding positions like Dr. Friedman mentioned that encourage a hypermobile joint placement. And again, just some more of the external supports are listed there. This is the review that Dr. Friedman mentioned. I just took a screenshot of some of it. This is amazing. So if you are someone who works with pregnant people, or if you're working in the OB setting and you have someone who has HEDS or hypermobility spectrum disorders, this article is amazing because it gives clinical guidelines. And I just did a few slides so you can see they have an overview. They talk about all different categories such as genetic counseling, pain management, comorbidities to consider, sexual intercourse, miscarriage, termination of pregnancy. So it goes on, and it really is a wonderful overview. Takeaways from these guidelines: during pregnancy, complaints such as hypermobility, pelvic issues, and joint pain may worsen. These symptoms can take longer than average to normalize postpartum. Wound healing and tissue scarring. People with HEDS tend to experience poorer wound healing and complex tissue scarring, such as atrophic scars or keloids. There's just some recommendations there. Anesthesia, as Dr. Friedman mentioned, they'll want to consult with the anesthesia department prior to, because they may need a higher dose. Optimal positioning for labor, being careful about the position, head, neck, shoulders, back, hips, knees. It's crucial to reduce risk during labor and possible dislocation, having positional aids as needed. And anyone who's joining us who's a midwife and doula, again, this is just reiterating all of the same points that we've covered this evening, but being aware of excessive movement at joints and risk of subluxation and dislocation for your patients. Remembering that this population does have challenges with completing exercise without injury, so being mindful of avoiding excessive stretching exercises if for the pregnant mom-to-be. Pain, multi-regional dizziness, especially if they have that history of dysautonomia, fatigue, weakness, difficulty coordinating movements. We covered this in a previous webinar in regards to proprioception and that decreased proprioception. So this population needs more external feedback when they are completing the exercises. Gastric bloating as well, if they have any other gastrointestinal symptoms. This is just, again, a review of some of the other orthopedic and pelvic floor considerations: slow healing, possible dislocation, subluxation, pelvic organ prolapse, urinary incontinence. And this is specific for postpartum. So I need to highlight that these considerations are for postpartum, so after they've given birth. Some of the wounds may be slow to heal. They still could be at risk of dislocation, subluxation, and or did it happen during birth, pelvic organ prolapse, urinary incontinence, and diastasis recti abdominis. I saw someone in the comments before, we didn't mention this yet, but one of the beautiful things about being hypermobile and or having HEDS is that these women tend to have quick deliveries. So that is one definite positive. Pelvic floor physical therapy, postpartum. So what we do is we're waiting until after that 6-week checkup. We will do an assessment of the diastasis recti abdominis, as well as checking for pelvic organ prolapse, and then doing slow exercise reintegration. We do talk about breastfeeding positioning during pelvic PT as well, just to make sure. It's very common and for women to end up in that forward head, rounded shoulder posturing with breastfeeding, and just correcting and getting out of that. Scar tissue assessment, and if someone had a C-section, we would do scar mobilization closer to 12 weeks to ensure full healing. So conclusion, pelvic floor PT is an important treatment for people with EDS and HSD. For those who experience pelvic dysfunction, there's many comorbidities that we have to consider and that require medical management. Being informed and self-advocating for yourself about the medical complexity is crucial, and then collaborative care is key for all people with EDS and HSD. Thank you so much. That was a very quick rundown of pelvic floor PT and pelvic considerations for people with EDS and HSD. Here's some of my references. Here's my contact info. Many of you may know that Inspira is located in Brooklyn, but we did also just open a location in Midtown. So happy to work with anyone at either of those locations.